So hello and welcome to yet another exciting episode of monthly webinar brought to you by IACCM. Today we'll be discussing everyone's favorite topic, that is emerging concepts in ARDS. And to discuss this topic, we have two eminent speakers with us from across the country. So we have Dr. Sameer Samal, who is working as a professor in some medical college, Bhubaneswar, who is going to discuss about diagnosing and defining ARDS, what is new, followed by Dr. Pooja Murthy, who is joining us from Aster Hospitals, Bangalore. She is going to give us an update on what is new in mechanical ventilation in ARDS, followed by a panel discussion, which is going to be moderated by Dr. Yash Javeri. So over to you, Dr. Sameer.
Hello, good evening, everyone. So is my screen visible now?
Yes. Now it is visible.
Okay. So good evening, everyone. So I am going to speak about the topic defining and diagnosing ARDS. What's new? So as we all know, the new global consensus guidelines have come out long after the Berlin guidelines after 12 years. So let's see what are the new changes. So brief history, it all started in 1967 by Ashbog et al. They had 12 patients, a case series, where they noted that PEEP was helpful in combating athletics and hypoxemia. Then we came in 1988 to the Murray score, where the lung injury score was calculated based on 4 components. And then we finally had a American and European consensus in 1994 regarding ARDS, where they were categorized into ALA and ARDS. It had to be acute onset with bilateral infiltrates on chest X-ray with a pulmonary capillary wedge pressure of less than 18. It should be non-cardiogenic. Then it came the Berlin criteria by the ESICM. So it was again acute onset that was defined. The duration was not defined in AECC, but in Berlin, that's defined it as 1 week duration with bilateral infiltrates, and it should be non-cardiogenic. The PCWP was omitted, and hypoxemia should be present with a PEEP of more than or equal to 5. And the severity was classified into mild, moderate, severe. And then in 2023, the global consensus. So why there was a need of new definition? So after the 2012, there were many studies that showed that SpO2 by FiO2 ratio, the Kigali index, was as good as the PF ratio and with less invasiveness. So, and many studies showed that it is good, it is validated well. So they tried of thinking, taking as SpO2 FiO2 rather than PF ratio as a criteria. And then came the landmark Floradlit trial, the use of HFNO with around 300 patients from France. With PF ratio less than 300, they were included. The primary endpoint was intubation by day 28. It did not differ. But in post-hoc analysis, in very severe ARDS patients with PF ratio less than 200, there was significant less number of intubations and significant mortality benefit was present. So the HFNO now became the next thing. And as we know, then the COVID-19 HFNO was of great help. And so it was gradually included in the definition that HFNO can be used to classify the ARDS. Also, this time they took into consideration the resource limited setting where there is non-availability of ventilators or ABG machines or bedside chest X-ray, and the increased use of USG in the recent years, even that was taken into consideration. So the drawbacks of Berlin criteria was that it excluded patients who were not on positive pressure ventilation. So they lost out on many ARDS patients. So the aim of this new definition was not to add more patients, but not to exclude the ARDS patients. So that was what the vision was. So there was again subjective interpretation of chest radiographs within different people. And so that was the reason. And the lung SEP trial also showed that there's an under recognition of ARDS going by the Berlin criteria. So that was the need of the new global consensus. So coming to the definition, it should be acute. According to the new global consensus, it should be acute, diffuse, inflammatory lung injury precipitated by a predisposing risk factor, mostly within 7 days. And increased pulmonary vasculature, loss of aeration with clinical hallmarks of hypoxemia, increased alveolar dead space, and decreased lung compliance. So this is the word-by-word definition by the global consensus. Now, what they did was they categorized ARDS into 3. That was non-intubated ARDS, intubated ARDS, and resource-limited setting ARDS. So this is a visual graphic. It is there in the consensus itself. So as we can see, the first patient is an intubated. Here we take PF ratio into consideration, that is intubated ARDS as per the Berlin. Then we go into non-intubated ARDS where HFNO is allowed. Here we take SpO2 by FiO2 into consideration, and then in resource limited, without HFNO or without any PEEP, even if the patient is on high oxygen flow, At 15 liter per minute, we can go by SpO2 by FiO2 ratio. So the definition, the risk factor, it applies to all the three categories that I discussed right now. The risk factor, it should be pneumonia or non-pulmonary infection or trauma or transfusion. Pulmonary edema, not exclusively or primarily attributable to cardiogenic, but cardiogenic patients can be taken if the presence of ARDS, a predisposing risk factor for ARDS is also present. The timing, 1 week of estimated onset, that remains, that doesn't change. Chest imaging, bilateral opacities, that was on chest radiography or CT scan as it was in Berlin criteria, but now the USG ultrasound guided diagnosis of ARDS was also taken into consideration. Now coming to the oxygenation and the severity of the ARDS. So again, now here where it varies, non-intubated, intubated and the resource limited setting. In non-intubated, PF ratio less than 300 or SpO2 by FiO2 ratio less than 315, but it should be kept in mind that the SpO2 should be less than 97. Why? I will discuss it later. Or with an HFNO with flow of greater than 30 liter per minute, or a PEEP of 5. And intubated, as we know, the mild, moderate, severe, it stays. But here, along with PF ratio, SpO2 by FiO2 ratio is also taken into consideration. And in resource limited settings, only SpO2 by FiO2 if SpO2 is less than 97%. So the changes, let's see what are the changes. The Berlin definition, it stated that it should be within 1 week. So the duration stays 1 week. It has to be within 1 week of insult. Now, HFNO were included in this to include COVID-19 patients. There may be incidents even in the future. So HFNO patients for capturing more indolent process, not acute in within 1 or 2 days, but more than 7 days, up till 17 days. Now coming to radiology, Berlin definition was only based on chest X-rays, but now the global definition allows using of ultrasound if the operator is well trained. Okay, so the rationale is CT may not be available or bedside X-ray may not be available at all settings, so ultrasound can be used. Now the PF ratio or the SpO2 by FiO2 ratio. So as per Berlin definition, there were 3 severity categories. The global definition says SpO2 by FiO2 can be used if SpO2 is less than 97 because it is validated as a surrogate, as I already told. And the review article was done by Dr. Mathey himself, who is the primary author of the global consensus. Now the PEEP by oxygenation, as I told, requirement of invasive or PEEP more than 5 is necessary at Berlin definition. The global definition allows HFNO or ARDS for resource limited if SpO2 by FiO2 ratio is also taken into consideration. This is just a review again, just to again get revised. So intubated ARDS, non-intubated ARDS in resource limited setting. So HFNO is allowed, SpO2 by FiO2 ratio is allowed. So the ARDS diagnostic approach, the advantages are that is recognition in spontaneous breathing patients because of the SpO2 by FiO2 ratio. There is no need of NIV or HFNO to diagnose a patient to be an ARDS patient. The adaptable criteria, that is for low resource setting, even they can use this definition to categorize this patient in ARDS as ARDS patients. Now there is a more number of population can be classified in ARDS that will help in our further research, and earlier recognition of ARDS because of this more adaptation will help in timely intervention. But the cons of this diagnosis, it is still inaccurate in borderline cases, like I said, in that nonlinear SpO2, as I told, I will tell later. The SpO2 is only sensitive when it is less than 97 because more than 97, the PO2 and SpO2, they vary. It is a sigmoid curve. Okay, so even minor changes in PO2 can cause huge changes in SpO2. So that is why it is borderline cases, very low risk of ARDS can get included into ARDS. So there is no formal testing, like no validation of whether these definitions hold good. So that requires validation in prospective studies, and the opacities that is noticed in the chest X-rays that can vary from person to person. So these are the cons. So as I told, the Kegel index, sigmoidal curve, the removal of PEEP may lead to misclassification of non-ARDS patient into ARDS. Now in use of USG, that can be false positive cases. So the new definition is broadly a syndromic label. It doesn't actually define ARDS as a whole, but it defines the syndrome and not the disease per se. Okay, so the subgroup differences, as we know, may not be here. So why they fall short? As we know, it is a heterogeneous disease, not a homogeneous. All the patients with similar PF ratio can go into different direction in their further course of disease. So what happens, we will discuss that again. So fixed thresholds for oxygenation do not account for the variability in lung recruitability, comorbidities, or underlying insult. The one size fits all approach needs to be changed. So we need more tailored therapies based on the type of ARDS rather than the severity of ARDS. we'll again discuss. So now what do EACSM has to say regarding these guidelines? They have formulated their own again in 2023, since the Berlin was originally devised by them. So let's see what they have to say. In the 2023, although they have not defined ARDS per se, but they have given us avenues which has to be, means research has to be done so that we can define ARDS more properly. So they have again allowed HFNO to be eligible for oxygen criteria. PEEP should be removed. And what goes against this consensus was this dilutes the severity of illness. Now, increased use of SpO2 FiO2, as it has already been validated, it is less invasive and more readily available. However, the theory going against it is inaccuracies in SpO2 measurement in dark-skinned person, in severe shock patients where the circulation is not very good, and SpO2 in excess of 97%, as I told, because of the curve. So chest X-ray, again, as I told, inter-observer variabilities persists. So CT-based criteria should be allowed, unilateral opacity should be allowed as per the ESSM people. And what they have noted that the time duration, they wanted to keep it long or short, but they have not yet commented properly. They said that in the 6 ARDS network trials, more than 10% rapidly improved within 24 hours. So whether they were actually ARDS. So they wanted to have a minimum period of stabilization after which they can be diagnosed as ARDS. But the problem was that the long period prevents early therapeutic intervention. Maybe they improved because of early therapeutic intervention. So they are not yet uncertain regarding the timing of the to be allowed. So they found that the conceptual model that is made by the global consensus, there is a disconnect between the conceptual model and the specific type of inflammation and host response to injury that varies from person to person in different ARDS patient, even though with the same PF ratio. So they found that there is a huge disconnect. So there is lack of means how to measure the inflammation in each patient, individualized patient, that is not present. As I told, one size fits all is not going to help in ARDS patients. So without a universal reference standard, so it is difficult to diagnose ARDS. So they thought that what they are now trying to achieve is going by the subphenotypes. As we know, there is ARDS is not more homogeneous. One size fits all does not work out. The mortality does not help in reducing as much changes we have done, but still the mortality hovers around 35 to 45%. So one size fits all is definitely not helping. These new definitions are not at all helping in creating new treatment strategies for these patients. So phenotypic classification, they thought may help in that. So like example, immunomodulators. So it minimizes harm for intervention not suited to patient subtype, as we have seen in case of hyper and hypoinflammatory. So each phenotype can have distinct outcomes. Okay, so hyperinflammatory and hypoinflammatory, we know it is hyperinflammatory is more people responsive, whereas hypoinflammatory is they have good outcomes with standard ventilation. There is multi-organ failure in hypoinflammatory and better organ function in hypoinflammatory, with higher cytokine levels in hyperinflammatory. Other shortcomings of the purely syndromic approach, like the global consensus, is that they facilitate identification of ARDS, but they do not differentiate the underlying pathology. So the treatment strategies are not adequate to improve mortality. So the syndromic labeling helps unify practice, but it masks crucial biological heterogeneity. So we must change from is this ARDS to know which kind of ARDS this patient will be having, which subtype. Okay, so the future prospects is like incorporating biomarkers like IL-6, SRH, imaging patterns, various imaging patterns, and compliance, alveolar recoverability. This redefinition has to be used in the future definitions. So we have to go beyond mild, moderate, severe based on PF ratio, and it should be dynamic. For example, in the first 24 to 48 hours, it can be syndromic to know the response. And in the late course, it depends on how the disease progresses, depending on the inflammatory type, whether it is hyperinflammatory or hypoinflammatory. So we may try in future defining ARDS based on these categories. So evolving approach of dynamic classification, repeated imaging, and biomarker checks bedside to know if we can define and categorize ARDS based on these new parameters. So we can have more trials focusing on subgroups, like selecting only hyperinflammatory ARDS for IL-6 blockade, and the necessity of robust bedside tools, or maybe use AI for classical analysis of already ARDS subpopulations. For the summary, ESSM 2002-3 and global definitions, they have incorporated HFNO, SpO2 by FiO2 is okay, and although it doesn't help in subtyping ARDS, but as of now, to include more and more, encourage more research, they include more patients in the ARDS definition so that we can have a large pool of data. And no single definition as of now fully encompasses the complexity of the ARDS. So the take-home message is that as of now we continue going by the current definitions, and we validate these by conducting more prospective trials and see if they're getting validated, like SPO2 by FO2 was done. And phenotyping is pivotal regarding hyper and hypoinflammatory subtypes, direct versus indirect etiologies. And as I told, the first 24-48 hours syndromic approach, beyond 48 hours, we may shift to phenotype driven or cause specific for better outcomes. Thank you.
Thank you, Dr. Sameer. I think it was extremely useful. Due to shortage of time, we'll quickly move to the next topic, that is on the update of mechanical ventilation in ARDS. And considering our exams are around the corner, it's going to be extremely useful for all our exam goers and all critical care professionals. Dr. Pooja Murthy is going to take this topic. Dr. Pooja, over to you.
Yeah, thank you. I just want to check if my screen is visible.
Yeah, Dr. Pooja.
Am I audible?
Yeah.
Yes.
And it's visible,
Not,
right?
yeah, full screen.
A very, yeah, yes, yeah. A very good evening to everyone, and I thank ISCCM for the opportunity. I think I'll just try to be a little fast to cover all the possible concepts. So we are dealing with ventilatory strategies in ARDS. And I think I'll not deal with the definition part, which has already been discussed. So before we head on to the management of ventilatory strategies, we should understand the concept of baby lung. I think majority of us know this. It is again an offspring of CT examinations, and it is equivalent to a functional lung size of a 5 to 6 year old. That is what we say, around 300 to 500 grams of aerated tissue. Essentially, we are not dealing with anatomical but functional lung size, because ARDS is a non-homogeneous disease and the available lung for gas exchange is very less. And the concepts like lung rest, low tidal volume ventilation, optimal PEEP, driving pressure, mechanical power, all these concepts have evolved from the concept of baby lung. So jumping on to ventilatory management of ARDS, the more core concepts would be low tidal volume ventilation, PEEP, preventing ventilation-induced lung injury, achieving targets of Plato pressure, driving pressure, mechanical power, which has been in discussion of late, and of course some rescue strategy measures like prone ventilation and ECMO. Low tidal volume ventilation has been the holy grail of mechanical ventilation in ARDS, I think, since 2000. Following the ARMA trial, here we saw a significant mortality benefit in patients who were ventilated with 6 ml per kilograms versus the conventional high volume ventilation, which was between 10 to 12 ml per kilograms. And they saw significant benefits. They saw definitely a mortality benefit. They also saw ventilator-free days, which were significantly higher in the low tidal volume group. They saw significantly less barotrauma. They also saw number of days or organ failures were pretty much reduced, or free from organ failure days was higher in patients who received low tidal volume ventilation. And since then, we've been following the low tidal volume ventilation strategies. The ARDS network, like all of us know, has given us a protocol for all patients with ARDS. And generally, we start with 8 ml per kg. First, initially calculate the predicted body weight as per these formulas. Start with 8 ml per kg predicted body weight, slowly reduce up to we achieve a volume of 6 ml per kg, and monitor the pH, Plato pressure, and oxygenation goals. The oxygenation goals will be have to have a PaO2 between 55 to 80 millimeters of mercury. Of course, PEEP settings will be they recommended using these tables, and Plato pressure was recommended to be around less than 30 centimeters of water and a pH of more than 7.15. So this is what was recommended by ARDSNet. Following this, many studies have come up. In this study, it showed that even adherence to low tidal volume ventilation showed mortality benefit. They said that if there was a 50% adherence to low tidal volume ventilation, the mortality reduced by 4%, and if there was 100% adherence, the mortality reduced by 7.8%. Many meta-analyses have been done and have significantly favored low tidal volume ventilations. So even the timing of tidal volume ventilation, and there are various studies which have shown that increase in tidal volume of more than 1 ml per kg predicted body weight from baseline of 6 ml per kg showed a higher mortality of around 23% in this study. However, the lung safe study, which is a large multicentric trial in 2016, did not show any major increase in mortality with a tidal volume of more than 7.1 ml per kg. But however, when it was clubbed with plateau pressure, PEEP, and driving pressure, it showed significant influence on outcome measures. So just giving low tidal volume ventilation is not enough. What we want to highlight here is it has to be combined with other parameters, PEEP, monitoring the driving pressures, plateau pressures, and all these things which will help us achieve good outcomes. Moving quickly on to plateau pressure, we all know the definition of plateau pressure, and this meta-analysis have shown that the tidal volume, a lower tidal volume, along with maintaining a plateau pressure of less than 27 centimeters of water, unlike 30 centimeters of water, which was recommended by the ARDS protocol, showed a survival benefit. Coming to PEEP, once we've got low tidal volume ventilation, the other the weapon which we have to fight against severe ARDS using mechanical ventilation is open lung ventilation. So open lung ventilation is very, very important, and the concept here is the PEEP opens the collapsed alveoli and improves gas exchange. Some of the studies have also shown the concept of PEEP responsiveness, which is defined as an increase in PF ratio of more than 20 millimeters of mercury after giving PEEP. PEEP is not all size fits all. It is individualized. Like the previous speaker spoke about different phenotypes, there are also different phenotypes which respond differently to PEEP, and low versus high PEEP, the constant debate is always on, and high PEEP is definitely is shown to be beneficial in some patients with moderate to severe ARDS who are especially PEEP responsive. Now, how do we titrate PEEP? Various methods have been followed, and various methods are also being added on. The ARDS PEEP table is the most common one. Best compliance method is esophageal pressure monitoring, driving pressure optimization, step-up approach, etc. Now, there are various advanced methods of PEEP titration that are being spoken about. One is the stress index. Here, it is on the pressure volume changes which we see on the pressure time curve. We target a stress index of 1 to say it is optimal PEEP. Electrical impedance tomography is another newly coming up method of PEEP titration. Here, the PEEP, the electrical impedance tomography determines if the PEEP is, it determines the optimal PEEP where the lung is least overdistended or least collapsed. So that is what we try to achieve. And of course, esophageal manometry. This operates under the principle that the esophageal pressure is a surrogate of the pleural pressure. Our aim here is to achieve calculate the transpulmonary pressure, and the end expiratory transpulmonary pressure is what we target. End expiratory a study which is called the EP-WENT2 trial. In the post-hoc analysis, they have shown that achieving an end expiratory transpulmonary pressure of 0 was associated with greater survival. Various numbers have been there. End inspiratory pleural pressure, transpulmonary pressure of less than 15 to 20, and expiratory transpulmonary pressure of 0 at or plus or minus 0.2. These are our targets when we monitor esophageal manometry, and we have to titrate the PEEP accordingly. Recruitment to inflation ratio has also come up in various studies. A recruitment to inflation ratio of more than 0.5 says optimal PEEP. However, PEEP is not without side effects. If you give optimal PEEP, we get alveolar recruitment, there is a decreased lung strain, there is good ventilator distribution, decreased shunting, decreased pulmonary vascular resistance, and decreased left ventricular afterload. However, overdistension has its own drawbacks. It increases the lung strain, there is increased pulmonary vascular resistance, finally leading on to LV strain and decreased cardiac output. So how do we approach any patient who has moderate to severe ARDS? He or she has to be put on lung protective ventilation, and we assess for lung injury pattern, the recruitability, and hemodynamics. If the patient is having severe hemodynamics instability, we titrate a PEEP of 8 to 10. If the lung is recruitable, we target a higher PEEP of 10 to 15 and always monitor for respiratory mechanics, oxygenation, the dynamic, the pressures, including plateau pressure, uh, 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 and if at all they do not improve with these things, we have to go for rescue measures like prone ventilation, ECMO, etc. The debate of high versus low PEEP is constantly there. Various trials have studied the risk benefit of high versus low PEEP. The LOVES and the alveolar trial did not show any mortality benefit but showed increased oxygenation. The EXPRESS trial also did not show any mortality reduction. However, the ARDS trial, which was done in 2017, showed use of higher PEEP with aggressive recruitment maneuvers led to higher mortality. Possible reasons were lung overdistension and hemodynamic instability. So, what do we do? Higher PEEP improves oxygenation but does not always improve survival. We have to tailor make and not use all size fits all approach. And if possible, identify the phenotype, individualize PEEP strategies, look for assess for lung recruitability using various possible methods which we have. Most important, see how the hemodynamics are and use a personalized PEEP strategy and which will lead to good outcomes. I will not discuss in detail about use of neuromuscular blockers. It is recommended to be used in moderate to severe ARDS. Of course, the Acute trial showed a mortality benefit, which was an older trial. ROSE trial did not show any mortality benefit, and it is recommended not in mild to moderate, but moderate to severe ARDS. Now, we've spoken about low tidal volume ventilation. We have spoken about PEEP. The most important one, I think, as discussed by my previous speaker as well, is to understand the severity and understand the phenotype. So two kinds of phenotypes, one is hyperinflammatory and hyperinflammatory phenotypes have been described, and people with hyperinflammatory phenotype shown to be PEEP responsive. And coming to rescue strategies, prone ventilation is one thing which has again shown significant mortality benefit. The landmark trial, the PROSEVA trial, which has shown an improved mortality in patients who were prone for more than 16 hours. Various meta-analyses have also reconfirmed this, and it is recommended to prone the patient for at least 12 hours in these studies. Various other ventilatory strategies like airway pressure release ventilation, time-controlled adaptive ventilation, high-frequency oscillatory ventilation, all have been tried in various ways in patients with severe ARDS. One thing is already ARDS is harmful. By putting the patient on mechanical ventilation, we should not induce further harm. And ventilator-induced lung injury is one thing which we are always worried about when we start a patient on mechanical ventilation. So tidal volume titration, PEEP optimization, optimizing driving pressure, all these are modalities where we reduce the ventilator-induced lung injury. So I'll just try to deal with the core concepts of driving pressure and mechanical power because it is very vital for us to understand these and target these within certain limits to achieve good outcomes. Driving pressure is the pressure that is required to have alveolar opening, and the simple formula of plateau pressure minus PEEP is what we use generally. A cutoff value of less than 14 to 15 is generally suggested to target for any patient who is on mechanical ventilation with ARDS. It has also been shown that any increase of more than 1 centimeter of driving pressure was associated with 5% increment in mortality. So we have to be extremely careful and cautious in monitoring such patients. It's not just low tidal volume ventilation, but also optimum PEEP is what affects patients with what affects driving pressure. PEEP titration, having individualized PEEP strategies, and tidal volume titration are very, very important to have driving pressure which is within normal limits. Now, is only tidal volume, PEEP, and driving pressure important to reduce ventilator-induced lung injury, or is there something we're missing? What about respiratory rate, airflow optimization, dynamic and static pressure changes that is caused by excessive lung strain? So, even these are known to cause ventilator-induced lung injury, and there comes the concept of mechanical power. It is derived from physics law, first law of thermodynamics, in which we say energy is neither created nor destroyed but transmitted. So during mechanical ventilation, energy changes from electrical, potential, kinetic, and heat energy, and all these changes leads to changes in the structural at cellular and tissue level, which can inflict ventilator-induced lung injury. So measurement. So various formulas have been derived for measurement of mechanical power using pressure volume curves and respiratory rate. So the concept here is a threshold of around 17 to 22 joules per minute is what is told for mechanical power. It is the amount of energy that is transmitted per unit time. So from the ventilator to the patient. So targeting less than 17 is what recommended in patients with severe ARDS. Various formulas, bedside calculations have been devised, some simplified formulas, surrogate formulas. All these are there, which will help us, calculate mechanical power, because generally it is, when we look at it, it feels very complex. But however, what is the applicability of mechanical power on the bedside? It is still evolving. There are various studies which have shown significant benefit, but I think we are looking for large RCTs for application of mechanical power at the bedside, and more simplified formulas which can be applied. One more formula, which is a surrogate of mechanical power, which was proposed by Da Costa et al., is also a simplified version where it 4 times the driving pressure multiplied by the respiratory rate can also be a surrogate for mechanical power, is what is being recommended. So we're looking for more options like that. So to summarize, ARDS management is not simple, complex, and it is not just low tidal volume ventilation or PEEP. It involves, of course, low tidal volume ventilation, individualized PEEP strategies, but also monitoring and keeping driving pressure under limits, mechanical power under limits, using rescue strategies like prone ventilation, ECMO, whenever feasible. Thank you.
Thank you, Dr. Pooja Murthy. The topic was quite vast and you covered each and every aspect of it. Thank you, Dr. Samir, also, because you both set the tone for the interesting section is going to come up next. So for the next section, the panel discussion, it's my pleasure to invite the moderator for the section is Dr. Yash Javeri. All of you know that he's the Vice President of ISCCM and he's a Director of Critical Medicine and Emergency Medicine at Regency Super Specialty Hospital, Lucknow. And the esteemed panelist who is with him to take the session, let me take my pleasure to first introduce Dr. Sumit Rai. I think no introduction required. He's the Director and Head of Critical Care and Medical Director of Holy Family Hospital, Delhi. Welcome, Dr. Sumit. Please open your screen. Yeah. Let me take my pleasure to invite Dr. Benani Poda. Madam is a Professor and Head of Critical Care Medicine at SGPGI, Lucknow. Welcome you, Madam, to the panel discussion. It's my pleasure to introduce Dr. Vinod Kumar Singh, who is a co-chair Institute of Critical Care Medicine, Sir Gangaram Hospital, Delhi. Welcome, Dr. Vinod, sir, for also joining with us. And Dr. Suresh Ramsubban, he's a senior consultant, pulmonary medicine and critical care medicine, Apollo Specialty Hospital in Kolkata. So over to Dr. Yash for taking the session forward for exciting panel discussion about the strategies in ARDS and other things.
Thank you, Dr. Jacob and Dr. Mona Lisa. The discussion what we are going to have is effective versus ineffective strategies for ARDS. It will be an oversimplistic view because there are too many questions to be answered. So I request the panelists to be brief wherever possible. So we'll start with the definition. If we make the right definition, half of the things are done. But the ARDS definition remains elusive and there is a lot of pendulum shift from time to time. I'll start with Dr. Vinod, sir. Too tight or too loose? What definition would you prefer? Why I'm asking this question is, even if it is a non-ARDS patient and we treat as ARDS, we are not doing much harm. So what will you prefer, too tight or too loose a definition?
Very good question, Dr. Yash. Actually, you want a good definition, not too tight and not too loose, to be applied to each and every patient who is suffering from ARDS. Now, the problem with present definition is that this definition might be helpful for the first 24 to 48 hours of ARDS. But once the patient landing up into the next stage of the ARDS, we need to have which phenotype of patient is that, whether the patient is having the poor responsive to all the ventilator management, like prone positioning, like recruitment maneuver, and all the rescue treatment, or the patient is not going to improve with all these measures, or we call it a conventional measures for the management of ARDS, and the patient should be shifted to the extracorporeal support. Why we need that? Many times we land up in doing more harm to the patient in proning and continuing the conventional ventilation. So at least after the 48 hours, we'll be able to define and stratify who are the patients who are not going to improve with the conventional ventilation. That's my take on the definition of ARDS.
Thank you, sir. My next question will be to Dr. Suresh. ARDS could be primary, it could be secondary. How important is it to diagnose the etiology of ARDS?
Absolutely essential. ARDS is a syndrome. You cannot treat the patient if you don't have the etiology. So I think the definitions are important because it's a syndrome. A syndrome is to recognize an entity so that we do no harm and have certain measures to help it. So the definition tells you that you are looking at an entity where you are having a PF ratio less than 300, you are having bilateral alveolar infiltrates, and you can do a set of interventions. But if you don't treat the underlying cause, it's not going to help. So please always remember, it is a syndrome. It is a syndrome. You cannot treat a syndrome. You got to treat a disease. You got to find an itis, whether it's a pneumonitis, whether it's a cystitis, whether it's a pyelonephritis. You got to find an itis. If you don't find an itis, you're not going to be successful in it. And then you will have drug-induced lung disease. You have mimics of ARDS, pulmonary hemorrhage. All those things will be essential to important. So I think every student who's listening in or anybody who's interested, remember it's a syndrome. You got to make a diagnosis.
Yeah. So the message is very loud and clear. If we treat ARDS with whatever strategies, resuscitative strategies and ECMO, unless we treat the root cause, we are not going to improve. Next question brings us to this discussion, the predictive tools for ARDS, especially in improving the prognosis. And I'll put this question to Dr. Soumitra, sir.
So, predictive tools in terms of the severity of illness, etc.
Yes, sir.
Just continuing with what was said, very well put by Dr. Vinod and Dr. Suresh Ramasubban. So definition, just because before we go to the predictive tool, the definition itself is important in the sense, keeping it wide. By the very nature, definitions have to be, on one hand, inclusive and one hand, separate things out, right? So a definition for a disease process, a larger disease process, can never be perfect. If we are imagining that the definition by itself will give us the phenotypes, that is not going to happen. Right. So that should be very clear, that the definition will be inclusive to a certain extent and separate out certain things. But phenotypes, subphenotypes has to be found out by us by different mechanisms. Okay. Having said that, because the predictive value is also dependent on the type of ARDS, as Suresh said, that what is triggering it, right? What is the trigger for the ARDS? So even that also predicts to gives us a value to the outcomes. And prediction models are important because, even if you look at the subphenotypes, which are part of the prediction model, that we found that the hyperinflammatory phenotypes tend to do worse vis-a-vis the hypoinflammatory, but also the etiology of it. So if it is an ARDS of pulmonary origin, the outcomes are poorer than non-pulmonary origin. And so predictive and the severity of illness, also the severity of ARDS, very strongly correlated in the lung safe trial with mortality. So I think it is important to have predictive models.
Right. And as you rightly pointed out, there are no definitive diagnostic criteria, and we do not have a differential, guidelines to diagnose, and there is a lot of overlap. So this overlap is beneficial to an extent that we are inclusive, but as Dr. Sumit and Dr. Vinod already pointed out, we have to subclassify them into various phenotypes so that we can treat them with some personalization also. This brings us to the next question, which I'll put to Dr. Banani Podar, madam. ARDS patients, what will be your targets for oxygenation and carbon dioxide and various other physiological parameters?
So one of the important things is that we need to be gentle when we ventilate, as has been rightly pointed out by Dr. Pooja, that on one hand, we are dealing with damaged lungs and we are giving them positive pressure ventilation. So we should not be inducing more harm. So having said that, we need to keep our targets very modest. So here is a situation where we would not be targeting the normal oxygenation and normal carbon dioxide. So we would like to keep very modest targets, and the oxygenation of 55 to 65, 55 to 70, 55 to 80 is acceptable, especially in the initial periods. Because if we target 80 to 100, which is like a normal oxygenation, we will actually end up giving them very harmful ventilatory settings. The second thing is about the carbon dioxide. Since we know that we are giving low tidal volume, trying to restrict the plateau pressure, we might actually, to a certain extent, be hypoventilating them. But that's not because we are hypoventilating them, but that is because, as Dr. Pooja said, there is only a small amount of lung that is participating in the oxygenation and ventilation. So we need to keep our carbon dioxide targets also modest. We allow the carbon dioxide to rise as long as the pH is above 7.25. There are caveats and there are exceptions to this rule, but this is by and large the rule. At the same time, we would like to keep an eye on the RV failure, on the RV of the patient, because if the RV is not doing well, then we might have to keep a slightly higher oxygen target and a slightly lower PCO2 target. But by and large, we need to be modest in our targets. Otherwise, we will end up, that is the most important concept, we will end up doing more harm, giving a lot more villi, because we will use higher power and higher driving pressure to get the normal oxygenation and normal ventilation.
Thank you, ma'am. As rightly pointed out, first hit we have to treat and we have to avoid any further second hit. Further second hit could be barotrauma, it could be ventilator associated infective or non-infective etiology. So we have to have an all-out approach to avoid any sort of secondary injury to an already diseased lung. I'll move on to the clinical management to Dr. Vinod sir. A diagnosed ARDS, it could be mild, moderate, severe. Will you offer non-invasive support or HFNC to start with? And when will you offer that?
Mostly the current practice is that if the patient has got mild to moderate ARDS, we can try the patient on either HFNC or non-invasive ventilation. But the point is that these trials should be done only and only in the high dependency unit or in the ICU itself. And we should be keeping very close eye when the HFNC or the NIV is going to be failure. Otherwise, the delaying intervention in such patients is going to have the bad outcome in cases of mild to moderate ARDS. In fact, in severe ARDS, these non-invasive methods are contraindicated because they are going to aid to the villi, they are going to aid to the lung injury. So these things should not be tried in cases of severe ARDS, particularly if the PF ratio has gone down to less than 150.
So HFNC, NIV. Dr. Suresh, I'll bring the next question to you. Awake proning.
Sure. As I said, will help. We've seen that help in at least in COVID ARDS. The thing is, most of the other people are, say, sepsis or pneumonia are hemodynamically unstable. So when you have an airway which is unprotected, you're leading to too many risks. But yes, if you're purely pure single organ failure with lungs and you're doing a moderate PF ratio more than 150 and patient is compos menti, I think fair enough it'll improve oxygenation by the same principle by improving ventilation perfusion matching as it would do when you're ventilated. When you're ventilated, it also acts as a recruitment maneuver, but when you're not ventilated, it just helps in improving your ventilation and perfusion matching. The only caveat to this when you're doing awake, as I said, is when people are sick, hemodynamically unstable, or slightly drowsy, it's okay. In COVID, when we used to have that patient where it's completely a single organ failure and no other organs are involved and they're fully awake and alert, then it's a great tool. But any other sepsis, pneumonia, just have to be a little bit careful about doing an awake prone. That's my take on it.
I'll move further leading question to this question to Dr. Sumit, sir. Combination of HFNC, NIV plus awake proning.
So before I go to that, one thing about the definition, and I tend to go back
Yeah.
to the definition. The new definition, it says HFNC at 30 liters. I don't know where they have come with that number, because every trial that was done on HFNC was defined at 40 liters. So that is one problem with that trial, with that definition. So that apart. So would I do this combination in a pay? No, I'm not going to do that. No.
Sorry.
Sorry. The reason is that, HFNC and proning maybe, but to combine NIV with proning is not an easy thing.
Yeah.
Second is the gains of proning in a spontaneously breathing patient without recruitment, with just the VQ matching. We don't even know the effect of the sponge effect that we call the trickling of secretions, etc. in a spontaneously breathing patient. We don't know this. And if you see the trial during the studies during COVID, the improved oxygen did not reduce the number of patients going on to the ventilator or the outcome, right? So I would be pretty, I would not be playing around like that. I would rather HFNC or with awake proning, not NIV for sure. And then if it is not helping, probably go in for, I would rather go for a little early intubation, risk early intubation over late intubation. And I agree with Dr. Vinod that probably delaying that would be a really bad idea. I would err on the side of intubating early and not try to do this. The role of HFNC with NIV combination is only for extubation purposes, where you have a patient. The studies which I've shown is that you have better reduced reintubation rates in patients who are possibly high risk for reintubation, right? So that's where it has been of use, but not in this subset. I would not.
Perfect. So general practice is that only, unless there is no consent for intubation, those are select criteria. Otherwise, please do not combine two difficult strategies in a single patient where intubation is possible. So the burning question which always remain, and to Dr. Banani now, timing of intubation, early versus late or timely?
Yeah, I think the best word there is timely. On one hand, we should not jump and intubate the minute you say that this is ARDS, because sometimes we have seen that they respond beautifully to non-invasive ventilation, maybe HFNC also. But at the same time, Dr. Vinod very nicely brought out that you should just be very cautious. You have to observe the patient very carefully and very closely and not delay intubation unnecessarily. So the criteria for intubation remain the same as for other patients. And if you are saying severe ARDS, then you just don't delay. You'll use NIV only for perhaps for the NIV or HFNC only for the time that you're needing to set up the ventilator. Your first strategy is intubation. Whereas if the patient is mild to moderate, you can put the patient on any of the two modalities and wait maybe for an hour, maybe for 2, and closely observe. So it is not early, it is not late, it is timely, and do not allow the patient to crash in front of you. That is the worst situation that can happen in an ARDS patient. And if in case, in addition to a moderate ARDS, you also have hemodynamic instability, or you have any other like severe acidosis or something like that, this is certainly not a patient in whom you would delay intubation. In good hands, intubation is not risky in the sense, that it is better to err on the side of intubating and taking control of the ventilation After all, even the spontaneous ventilation, the patient can keep having what is known as patient-triggered self-inflicted lung injury. So if you allow them, we did a lot of this, especially in the first round of COVID. We were all scared of intubating. We kept delaying intubation, and these patients had really wretched outcomes. So there is no logic or justification for doing that. And mechanical ventilation in ARDS is now while quite well oiled. It's not that every patient is going to come out, but it's not that we are going to lose every patient just if you put him on the ventilator and you're scared of VILI.
So timely intubation, if you have to err on the side of early. If our residents or some EICU colleagues call us to intubate or not, I always tell them if there is a doubt, you better intubate and let the things flow as per the protocol. Work of breathing is the single most important indicator which should decide on intubation rather than absolute numbers. This is what we practice. We go on to the next question to Dr. Vinod. We have many questions to go, so I'll request everyone to be a little fast. Steroids, when and when not, and the dose.
Yeah,
Vinod,
this is
sir.
a very tricky question, and
Yeah.
mostly it depends upon whether it is a pulmonary or extrapulmonary ARDS. Okay. Most of the time, if it is a pulmonary ARDS and post-pneumonia ARDS, leading to complication, pneumonia has complicated like ARDS, then we should start methylprednisolone early. That what we do is we start at a bolus dose of 125 milligram, and then we are going for 1 milligram per kg body. We are not giving Rexona, we are not giving Efcordine in cases of the cases where there is pulmonary ARDS. Now, when not to give ARDS in cases, most of the time, if it is a sepsis-induced ARDS, and unless there is a requirement for the sepsis, Efcordine because of the sepsis and vasopressor requirement, then only we give steroid, otherwise we not in such cases. That's how I follow my IC.
And the duration generally prescribed by SCCM, ESICM group is 14 days. So 1 milligram per kilogram per day of solumetrol for 14 days, and duration could be differed. Next question, Dr. Sumit sir. Various other adjuvant therapies, avipradil, ulinacetin, Sepsivac, and endless list. Does anything has a role? Should we be using it or not?
Can you hear me? Because your voice
Yes,
broke
sir.
in the middle. Yeah, right.
Yes, sir.
I don't think there is any of these have proven themselves yet. Aviptadil, the basis of it, as you know, I mean, it's the new supposedly exciting drug on the block, did some benefit supposedly in improving oxygenation, not really outcomes during COVID, but it is also based on its action. The VIP, it's a VIP, so its action on the ACE receptors and COVID attaching itself to the ACE receptors. That could also be a reason, other than reducing the leakiness and increasing the surfactant in the alveoli. So some degree of potential in terms of theory, but has not proven itself yet. And the worrying sign always is that why is industry not going for a large RCT? Okay, so that is always a sign that there are doubts. So that is one thing. And others, I mean, anti-inflammatory therapy. So there, I think Dr. Samir said that should we look at the phenotypes where there is hyperinflammatory subphenotype, that should we look at immune suppressive therapy? That has been disastrous in sepsis, actually. So any immune suppressive therapy would be disastrous. Immune modulation in terms of those, actually what has been found is immune modulation in those who have an immune paresis could be of benefit, rather immune modulation, not stimulation, rather than anti-inflammatory therapies. The steroids, again, as Dr. Vinod touched upon, not very high dose, early on, not in viral pneumonias, and the dose would be, equivalent of about coming down to 1 milligram of solumetrol. So most immunosuppressive therapies would be problematic at this point of evidence for both sepsis and for ARDS.
Yeah. Because it's a very, very complex interplay of various
Yes,
mediators.
absolutely,
So there are
absolutely.
various reasons we don't have time for that. But the
Yes.
bottom line, as Dr. Sumit sir told, nothing works. So please do not venture into adjuvants except for steroids. Dr. Suresh and Dr. Banani, I'll put this question to both of you together because Dr. Banani can give us some pediatric perspective on this. Inhaled nitric oxide, prostaglandin, prostacyclin, whatever. Is there any role for adults or for pediatric non-neonatal meconium aspiration? Dr. Suresh and Dr. Banani. Madam.
I can tell you with a little bit of US experience, everybody
Yeah.
gets put on inhaled nitric oxide before they do anything. So, but again, it does improve oxygenation, but hasn't been shown to improve outcomes. So again, if you're not in a center where you have easy availability, I won't do it. You don't have to procure it or things like that. It doesn't make a huge sense. But if you are in a cardiothoracic center where they're using already inhaled nitric oxide and you have it, why not? So that's kind of a attitude that most of the US centers have about using it. If you have that experience and you have the ability to use it, go ahead and use it. It might improve your oxygenation a little bit, and especially when you're awaiting this thing. But otherwise, no. The answer is no. I won't do it in the house.
So the best practices and most of the centers don't do it because we do not want to confuse the audience. Sorry. Madam, pediatrics.
Yeah, pediatrics also, as you said rightly, in the neonatal age, apart from meconium aspiration and such other kind of situations where you end up having a kind of a fetal circulation with very high pulmonary vascular resistance, you might want to use it, but otherwise, no. Post-op cardiacs, there are certain indications in which you would use it, but then that is not really an ARDS, that is low oxygenation for some other reason. So really speaking, no indication for any of these, and it's too cumbersome a therapy to embark on, and let's leave it to the neonates. That's it.
We'll go on to the next question. Now we have intubated this particular patient. We initiate lung protective ventilation. The only proven intervention is probably lung protective ventilation, however we do it. So Dr. Vinod sir, you start with some sedation, do deeply sedate the patient. Still, there is no synchronian work or breathing remains high. Muscle relaxant, when will you use? When you won't use, how long will you like to use? Vinod sir.
Basically, if you ask with the use of the muscle relaxant, this you use as a rescue treatment only. If you are trying to, if my patient is not improving with the lung protective ventilation with sedation, then we can go for using the muscle relaxant. Second condition where we use the muscle relaxant, if you are proning the patient. And this period of time when you prone the patient, we use the muscle relaxant and just for 24 to 48 hours, and we try to keep the patient on a deep sedation. Third, where we find that there is a lot of dysynchrony or asynchrony between ventilator and patient, then only you can use for muscle relaxant. But we try to keep the muscle relaxant time period is limiting up to the 48 hours, not going beyond the 48 hours.
As less as possible, only as rescue therapy, and probably shorter acting agent atracurium, since atracurium obviously fare better than other agents. Next question I will bring to Dr. Sumit sir. Fluid strategy, euvolemia or hypovolemia? Most of us do hypovolemia. What is your take?
So it depends on you have to clinically differentiate the subphenotypes, and the evidence also suggests probably we practice that without having known the subphenotypes at some point of time, but we tend to do that. That what has been found in the latent class analysis by Caroline Calfee, etc., is that the subtypes where they have a more leaky endothelium with a more inflammatory response do better with less fluids. So if you should keep, seeing that if probably those patients who are requiring higher PEEP, okay, have a more inflammatory response, would do better with less fluid. That is where I give less fluid. And those not requiring high PEEP with less leakiness, with the extravascular lung water not high, there I would maintain euvolemia. So I do differentiate between the two phenotypes. There's no perfect method right now. We are actually doing a study, but in general, a clinical sense of the phenotype they are fitting into. Usually those requiring higher PEEP would do worse with more fluids. and that has been in Caroline Calfee studies and shown, and that is our clinical. Most of us clinical experience would be that. Otherwise, euvolemia in that subset probably some degree of resuscitation, de-resuscitation. Sorry. Yeah.
Dr. Suresh, recruitment in terms of recruitment maneuver, yes or no?
No.
We will have a rapid fire because many
No.
questions and less time. No.
No.
Except for like drainage of pleural effusion or decreasing IAP. Otherwise, no role of recruitment maneuvers.
Absolutely. Increases
Perfect.
mortality.
Yeah. Dr. Vinod sir, does any mode has advantage over other? Yes or no?
I don't think any mode has advantage in the routine management of ARDS patient, whether we are using APRB or whether we are using a pressure control or we are using a volume control. There is no added advantage, sir.
We go on to the same case. We have intubated the patient and still the saturations are below 84, 83. When will you like to prone, Dr. Sumit sir?
When will I like to prone?
Yeah. And same question is also for Dr. Banani, considering it a pediatric patient.
Prone early. If we have titrated the PEEP, I believe in titrating the PEEP for two reasons, not just for reducing shear stress, but also to reduce dynamic strain, which is one point that is missed out, is that if we improve the FRC, the dynamic strain also reduces. It's not just the stress which reduces. So in spite of titrating the best possible PEEP and fluids and vasopressors, perfusion, the VQ matching with perfusion, if it's still the PF ratio remains below 150, I would prone early within the first few hours also. Yes, early. And for
so
long,
most of the
15 to 20.
time, if your patient is having high oxygen requirement and you feel patient will have a PEEP of 8 with an FiO2 of more than say 50, we will prone directly without any module concern.
8 depending on
8 to
how
10,
the
yeah.
I don't go by the PEEP number.
Yeah.
I go by the PEEP, titrating the PEEP individually. If that patient, if I type 16 PEEP, the driving pressure is 14. FiO2 has come down from 80 to 40 or 45, right? I may not prone. Okay, if the PF ratio remains above 150. But if it is doubtful, borderline, I will prone.
Madam, your practice for pediatrics?
Yes. Prone is a very useful maneuver, and we've been doing it for years. In fact, even in neonates, when I was a student, we used to do prone ventilation. So it is a very useful maneuver, and it is actually easier in a child also, as you might imagine, except that you will need proper sedation and proper maybe neuromuscular blockage. But it is a very useful proposition. And also, previously we would not prone for such long durations, but now definitely above 12 hours is what we use. So 16 hours as in adults, similar to that is what we do. As far as PEEP is concerned, I completely agree with Dr. Sumit that we need to individualize. Not everybody will need high PEEP, not everybody will do well with low PEEP. So we need to individualize for each patient and see. The only thing that against proning will be, number one would be if you have a patient who's very hemodynamically unstable, then you probably wait for him to become at least come to a static dose of vasopressors. And the other thing could be if in case there is sometimes intubation trauma or anything and he's bleeding from the mouth. So that's another thing that you might want to wait. Otherwise, we just don't wait. We'll just go.
Just one addition, sorry. Just one addition. The one thing I forgot to is that not just the PF ratio, I look at the carbon dioxide and the right heart pressures. If the carbon dioxide remains high, in spite of the PF ratio being high, better than 150, and the right heart pressures are worsening, the right heart failure is, then also I would like to prone with slightly reduced PEEP, which would reduce the right ventricular failure probably. So that is the balance which I look at, not just the PF ratio. That's what we do in practice. Yeah.
2 points. Bronchoscopy, unless there is a compelling reason, do not do bronchoscope these patients. Tracheostomy, obviously you have to tracheostomize them on time. But in the acute phase of ARDS, when the PEEP requirement is too high, probably that is not the right time to tracheostomize these patients, because at times people try to tracheostomize very, very early. Dr. Vinod, this penultimate question is to you. ECMO, when will you proceed? Very, very short, sir.
Yeah, see, if you look at the different criteria for putting the patient on ECMO, the CGM criteria has used the different, like if the Murray score has gone more than 3, then you try to put the patient on ECMO. Eolia has the different criteria, but what most of the people follow is that the ELSO criteria. And the ELSO criteria says that once you have prone the patient with PF ratio is 150 and one less than 150, and then you evaluate the patient. If the PF ratio is less than 80 for 6 hours, or the PF ratio is less than 50 for 3 hours, or the pH has gone to less than 7.25, or as Dr. also pointed, the CO2 has gone up to 60 in spite of the conventional ventilation. These are the criteria to put the patient and to select the patient for the VVA.
Dr. Suresh, last question to you. ARDS survivors, what do they expect? And palliative care in acute phase of disease and later on for ARDS patient.
ARDS survivor?
Yeah.
No, what do they? I didn't understand the question.
What do they expect from their lives, the ARDS survivors?
So as I said, so it depends on majority of the people don't get into a fibrotic phase. This is one thing which we have seen as a follow-up in my pulmonary clinic is that you don't see that kind of a fibrotic lung that happens with, say, just a necrotizing pneumonia. They tend to have much more fibrotic lungs and much more sequelae of bronchiectasis and things like that. ARDS, when they recover, if they are into the fibroproliferative phase and they recover, they do very well. And there's hardly any fibrosis that you will see at 3 months, 6 months, and 1 year. So that's for sure that they have a good outcome if they really manage to get it. But yes, some people who recover, who get into the full fibrotic phase will have some issues. But I would say a majority of them do, especially younger people, single organ failure. In COVID, we have seen especially a phenomenally good recovery, especially in the second wave, where there was hardly any, despite using bad lungs, they do recover very well. Palliation, organ failures, when they go, I think futility of care, that the principle to be followed is the futility of care. Once a couple of physicians feel that this is futile care, and despite all efforts, this is going to be futile, then I think withdrawal of care should be, or a ceiling of care should be initiated according to the local laws of the state or the country.
Thank you. Dr. Sumit, sir, you are coming up with ARDS guidelines from ISCCM. What do we expect in those guidelines?
So these guidelines are actually just additional points to what they already are there. If we differ from them, anything that is existing significantly, or if we want to add in a resource limited setting, if there is anything else we could do from what the European and American, we don't want to, as we keep saying, reinvent the wheel. So I cannot tell you what we can add because it will only be arrived at based on the PICO method that we are using to gather the evidence. But the focus areas are what has not been touched upon in those guidelines. There are doubts there. And the third is that resource limited settings.
Thank you. Thank you, dear panelists. And
Maybe
over to
we
Dr.
should say
Jacob.
Maybe we should say something about the ARDS in the patients with tropical illnesses, because sometimes
yes, we are doing that.
You
yes,
can
we are doing that.
you
Sorry.
can get away without intubating them actually.
Yeah, we are to also yes. Sorry, I should have touched upon that. You are part of that, I think, right? The tropical. Yeah. So there are yes.
Dr. Jacob, thank you. Thank you for dear panelists. Over to you, sir.
Yeah. Thank you so much, Dr. Yash and the panelists. We have two questions which I thought, okay, I'll just share because a lot of exam going students are there in that. The one question is that when patient requires more PEEP to maintain oxygenation, that means leaky endothelium, targeting hypovolemia can reduce the cardiac output and circulation, further decrease in oxygenation. So what happens? We may need to increase the volume, and which phenotype is hyperinflammatory type or hyperinflammatory? That is one question asked. The fluid in the leaky patient with hypovolemia.
Right. So, leaky. So then you need vasopressors, not hypovolemia. This is basically the leakiness will not come in a hypovolemic shock. It will become in a distributive shock with an endothelial glycocalyx damage. So giving fluid in a hypovolemic patient with a leaky endothelium is a bad idea. Okay. So probably titrate your vasopressors to improve the perfusion. So that is what we have to look at. That is for true of sepsis also. Second is that So we are trying to increase the preload with the vasopressors. The other misconception, and I want to emphasize that PEEP does not cause hypotension if it is titrated. If you are not pushing the PEEP to reduce preload, increase right ventricular, reduce right ventricular outflow into the left ventricle, into the left atrium, it will not reduce, it will not cause hypotension. And that is the titration. And young people, now everybody is trained in ultrasound. Use the ultrasound to look at the right heart, look at the preloads of both sides and look at that. So I think that concept has to go, that PEEP reduces preload. It has to, if it is titrated properly, it does not. Second, that I said, if it is a leaky endothelium and hypoperfusion, then use vasopressors rather than volume. And that is the interesting thing that study came out with, the latent class analysis, that actually patients with more shock did worse with more fluid. The phenotype, hyperinflammatory phenotype, which had more shock, did worse with more fluid. So actually that just proves what I was trying to emphasize.
Thank you, Sumit sir. One more question.
Just to add on to that, Sumit sir.
Yeah, please, sir.
Just to add on to that is the fact that the PVR curve with PEEP is a U-shaped curve. So both excessive PEEP is harmful and lower PEEP is harmful. So it's the same thing. So the pulmonary vascular resistance changes. If you give too much PEEP, it will cause hypervascular resistance, and that will lead to a RV failure or acute cor pulmonale. And if you don't give too much PEEP, you have atelectasis and hypoxia that leads to low PVR, and that leads to, again, further hemodynamic consequences. So it's a U-shaped curve like alcohol. So please drink carefully.
Thank you, Dr. Suresh. And one more question, probably Dr. Vinod can take the question. Is ECMO helpful in patient reaches the fibrotic phase of ARDS?
Yeah, see, the time limit of ECMO is if the patient is on ventilator less than 7 days. And if the patient crossed 7 days, most of the time the ECMO is going to be futile. And the fibrotic ARDS, by definition, is that if you have crossed the 7 to 15 days. So ECMO is only helpful in fibrotic ARDS when you are planning to go for a lung transplant. Otherwise, there's no use of putting the patient on ECMO if the patient has reached to the fibrotic ARDS.
Got it, sir. How do we assess bedside which phase of ARDS he is currently in?
One is the days, how much days the patient is on ventilator. That is the most important thing. That if the patient has crossed more than 7 or 8 days on ventilator, as used in seizure criteria more than 9 days, even the other criteria also has, many studies have shown that the limitation of the ventilator days is 7 days. If the patient is in mechanical ventilation for more than 7 days, and the patient, now you are trying to put the patient on ECMO, the patient will not going to make on the ECMO, and ECMO is going to futile in such cases.
Take on it.
We don't
standard is
go for it.
One can also see the inflation recruitability ratio, because that will
absolutely
tell you whether it is fibrotic or not fibrotic.
Absolutely.
The best one is when the people say, "Aaj X-ray better lag raha hai," and the patient is still hypoxic, then you know that he's in a fibrotic lung. The alveolar phase is gone. And that's when you say, "Aaj X-ray better hai," and the physician says that, and your patient is still dying, you know that he's in a fibrotic phase. The other is obviously dead space fraction, very useful. And increasing dead space fraction predicts mortality better than that. So as your CO2 starts going up, in addition to your oxygenation, so be worried about the fact that your lung is getting a little bit less working than what normal lung is, less elastic and more fibrotic.
CO2 is actually a better indicator sometimes.
Most of the time. Most of the times.
It's actually one of the oldest papers, 97. Dead space fraction predicts mortality. When it goes from beyond 0.3 to 0.5, it predicts mortality the best. Still probably and as good. And nowadays, probably RV dysfunction predicts mortality, the same thing.
And that is where, just to add, RV dysfunction, probably that's the subset where nitric oxide usage should be studied. I'm not saying used. That is the subset, subphenotype, which should be not phenotype, probably subtype, which should be looked at.
So that's what exactly happens in the US in any good center, is that you will have the benefit of doubt. That's why when I answered this question, and Yash said, don't confuse the audience. I agree with the audience.
Sorry about
we shouldn't confuse it. But that subset of acute cor pulmonale, the subset of PA pressures rising, that subset of hypoxic vasoconstriction causing hypoxia, and causing pulmonary vascular resistance to go up. That subset, the PVR goes down, your oxygenation improves. Dramatic response. I have used it a few times and it's a phenomenally dramatic response, but it doesn't
Dr.
improve
Vinod,
mortality.
Dr. Vinod, and we have used it in Gangaram at one point of
Yeah.
time.
Yes,
I mean,
we
they
have
still use,
used in many patients. We have seen very beneficial in
oxygenation.
For
Yes,
just
true.
oxygenation, for just oxygenation,
Yeah.
not
Can I just
mortality.
add? Can I just add
Yes, madam.
one
Yes, madam. Please go ahead.
important concept not related to what is being discussed? Students sometimes tend to look at the PCO2 which is rising, and they tend to either increase rate or increase expiratory time. But what we have to remember in ARDS is that unless you recruit that lung, the lung will not participate in oxygenation. It will not participate in ventilation also. So this is one situation in which perhaps you should not be tempted to increase rate by looking at the PCO2 or increasing the expiratory time. If you keep a good eye time, the lung will get recruited. That lung will start participating in ventilation and oxygenation, and your PCO2 will probably conversely fall if you are able to get some more lung segments into it. So this is a very important concept, and I've seen this mistake many a times.
Thank you.
Looking at the expiratory time constant. Yes, very, very important.
Thank you so much. I think let me start thanking each one, because the first, the speakers, Dr. Pooja and Dr. Samir, I think they took the topic with grace and with a lot of clarity, and covering the entire topics mainly for the exam going students. And when you talk about Dr. Yash, he expect answers to be point blank questions and point up to the point answers. That he made it very clear right from the beginning of this triggering
He held us at
factors.
gunpoint.
Yeah, it's at gunpoint. Triggering factors of ARDS, which is very well explained by all the panelists, and to the end where the palliative care and post ARDS survivors. I think the entire topic has been covered with a lot of clarity and within the available time. So thank you, all of you, Yash, Dr. Yashar, Dr. Sumit Rai, Dr. Benani Poda, Dr. Vinod Kumar Singh, Dr. Suresh Ramsubban, and with me and Dr. Mona Lisa and Chirag, we thought we'll wind up the section for the time being. Festival greetings for all of you for the weekend. Good night and goodbye.
Thank you, Dr.
Good night.
Varghese. Thank you,
Thank you.
Mona Lisa.
Thank you
Thank
so
you,
much.
Dr.
Thank you.
Thank you, Chirag.